My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. Welcome to this episode of Operate with Zen. Today, I've got the great pleasure of being joined again by Dr. Kyle Richards. Kyle, for people who may have missed the first one, introduce yourself to the audience.
Yeah, thanks, Phil. Great to be here. I am, let's see, where do I start? So I'm an associate professor at the University of Wisconsin in Madison, Department of Urology. I'm a urologic oncologist with a focus on mostly bladder cancer. And I'm also the chief of urology at our VA hospital, which is right next door to the main university hospital. Father of 2 daughters, husband, amongst many other things. And I'm really excited to be here today, Phil.
Great. I'm excited to have you too. And today we decided to talk about complications. And anybody who operates has complications. John Gerhardt, who is a pediatric urologist giant at Hopkins when I was there, always say, you shake enough hands and somebody's going to drop dead on you. And the same kind of analogy holds true for surgery. If you operate, whether you're doing big cases, little cases, you do enough operations, people are going to have complications, and it happens in our field. It happens in any field. And I give you a lot of credit, our bladder cancer specialist, for surgeons who are not as familiar with urology and urologic oncology. Bladder cancer specialists deal with a lion's share of complications in the urologic oncology world because of all of the bowel work and reconstructive work done there. So with that kind of foreground for the audience who may not be familiar with bladder cancer work, kind of tell us about your practice and your kind of philosophy on complications when they do happen.
Yeah, I mean, I think as someone that does a large amount of bladder cancer work and cystectomies, complications are something that I feel I can speak a lot about because it's something that I, live day in and day out. It's a challenging operation, challenging patient population. But my experiences with complications, I think, and the things that I want to, share with the listeners, is not only germane to patients that have cystectomies and doctors that take care of patients that have cystectomies, but really any surgeon. I think these are things we'll talk about today, Phil, as you know, I think would be applicable to a wide array of different patient populations. And when I was going through training, I've been in practice for 8 years now, almost 8 years. And I just remember really the only time you talked about it was at your department's M&M, morbidity mortality conference. And as a resident and fellow, you're part of the cases, you're part of taking care of the patients, but the buck really stops with the attending surgeon. And so although when I remember being a resident fellow, being feeling bad for the patients, I always knew, well, it wasn't my fault necessarily because I'm a trainee. And then pretty soon you're no longer a trainee and the buck stops with me or with you. And that feels a little different. And for me, I didn't really have a way of, understanding how to deal with those feelings when a patient of mine, now that I'm the attending, was not doing well or, was having a bad outcome. And that's when I started, as I've seen many complications in my 8 years as being an attending, that's when I started to think, we have to do better as a field, I think, to help our surgeons out. You hear about burnouts and physicians and suicide, and we have to do a better job of maybe normalizing the discussion so that we can all help each other out. Because like you said at the intro, anybody that does any surgery, you're going to have complications at some point in time. Even though it seems like I have a large volume of them in my practice, may not be the same for everybody, but I think having a large volume of complications based on my patient population has helped me to figure out a system to maybe deal with them more effectively.
Yeah. Well, let's start there, Kyle. So tell us, listen, it's let's say it's Wednesday. It is not Wednesday when we're recording this, but you did an operation on Monday. It's Wednesday, and a patient's having a complication. Patient's having an issue. So let's walk through it. What happens in the hospital? How do you address that patient? How do you address the family? What's your style and kind of your procedure for do that? We'll walk through nuts and bolts, and then we'll start getting into some of the more abstract portions of this.
Yeah, I think that's a good way to think about it. Yeah, so nuts and bolts, for some of the younger surgeons out there that maybe they're experiencing some of their first few complications as an attending. My advice is always, and I teach this to my residents, is that's the time when you need to round on that patient, twice a day, maybe even 3 times a day. You need to be hands-on. You need to go to the family and be open about what's going on and explain to them, to the family and the patient, exactly what the issue is. And if you don't know, if it's still kind of nebulous, you're still trying to figure that out, it's okay to say, we don't know what's going on, but we're going to figure this out. And the family wants to see that their surgeon is fully invested. And so that's the tendency, I think, for some people, is to run away or to hide in their office. But that's actually a bad thing, I think. You want to be at the bedside as much as possible and be an expert communicator with the patient and then the family, letting them know that you're trying to figure this out. And if you know what's wrong, it's even okay to say that you're sorry that this is happening. It's, I think we hear that, well, maybe you shouldn't apologize because that is an admission of guilt. But in actuality, I think patients and families may want to hear that from the surgeon, that they are sorry, because that shows that they're fallible. It shows that they care, and it creates a connection. And patients understand, if you've done a good job counseling patients before their operation, they understand that things can go wrong. It may be outside of your control or their control. So it's okay to say that you're sorry that this is happening. Hey, Mr. Jones, this is not a real patient. Sir, I'm sorry that this is happening to you. We're going to do everything we can to fix it. And I think patients really can relate to that. So the key is to be there, run towards the patient, not away from the patient, and be an expert communicator with the patient as well as the team, because there could be a lot of confusion from the nurses and other team members, care team members. So make sure you're over communicating to everybody what's going on, and that you're the captain of the ship, so to speak.
Yeah, I think that's a great point and great summation. I mean, I think you want to be present, right? And this is not necessarily in the mindfulness sense of it, which is helpful, but you physically want to be present with that patient and with that family. And I see a lot of junior faculty get into the problem of running away from complications, just as you said. And you can often alleviate a lot of the anxieties and the distress that comes along with a complication or when things go badly by being present and being there for that family. And I'm not necessarily advocating for this, but I do give patients my cell phone, and especially when there's a complication or an issue, they want to know that you're reachable and you're accessible. And you say, listen, if there's a problem, at 2:00 in the morning, we want to know about it, and open up all lines of communication so that they really do know that you care and that you're present for their loved one. Because it's shocking, even though you've counseled patients and you talk about complications, you talk about what they could be and what can happen, it's still really tough when they happen. And none of us wants them to happen.
The other thing I'll add, Phil, to that is that I forgot to mention is sort of the concept of loading the boat. That, and what I mean by that is don't be afraid to call a senior partner. And I've done this many times. Hey, there's this weird thing going on with my patient. I'm not exactly sure. Can I run this by you? Call another service. I frequently will consult general surgery, another surgery service, if I'm not sure, what's going on, or if I'm concerned that they may be having a bowel complication, maybe I'll get a colorectal surgeon involved or a vascular surgeon. So don't be afraid to, phone a friend, so to speak. I think a lot of times the surgeon feels like, well, I'll take care of it myself. We'll be fine. I'll figure this out. But it can be reassuring if I think, we should manage a problem. That was weird.
Yeah, that was weird. Sorry. Go ahead, Kyle. Sorry, we lost you for a second there.
No worries. But I think if I get another service if I'm going to manage a complication one way, but I'm not, maybe I'm 90% sure that that's the correct thing, but I won't, but I'm not 100% sure. And I get another surgeon, maybe a general surgeon, to come by and say, hey, I'm going to manage this problem this way. Do you agree? It helps to, you're not only sort of covering yourself, if you want to think of it sort of medical legally potentially, but you're also just getting another set of eyes to look at things. Because sometimes you can get tunnel vision and narrow-minded dealing with the complication, sort of managing it. Same thing intraoperatively. We've sort of been alluding, I think, a little bit to sort of post-operative complications, but you might get into trouble in the OR. So the concept of loading the boat works good in that sense too, because if I know that I'm going to have a tough case and I might, get into some major bleeding from the aorta or something, might not be a bad idea to have a vascular surgeon ready to jump in. That's familiar with the patient, as opposed to just sort of calling the on-call vascular surgeon that maybe they're not immediately available for. Or if I know that I'm going to have some issues with bowel adhesions and I might have to do a bunch of bowel resection, I usually get a colorectal surgeon on board ahead of time, so that you can sort of plan ahead and kind of nip those complications in the bud, so to speak.
Yeah, you see people compound a complication or a bad outcome by trying to kind of go internal. And our colleagues have all been there. Every surgeon has complications and issues. And like you said, loading the boat, reaching out, bringing other people on is actually a huge, not only help to you practically, but it also tells that family and that patient that you really care about them, and you are humble about this. You want other people involved. You're not hiding this complication or kind of, keeping it a secret. You want other people involved. You want the best outcome for them when things don't go well as when they do go well. And I think that's an important message. Yeah, and I think one of the other really important things that we kind of allude to, or not allude to, you said, is, it's okay to apologize. It's okay to say, listen, I'm really sorry these things happened. And, I've even said to patients, in retrospect, I wish I had done this differently. But at that time, we had been acting on the best information we had. And these are the reasons, we did X, Y, and Z. And unfortunately, this happened. And I think honesty is hugely important with patients. And the other part of being honest is, this term has a negative connotation, but it's controlling the narrative a little bit, right? You want patients to understand what's going on, and providing the truth does that. The story, and as you said, talk to the nursing team, talk to, if a patient's in the ICU team, make sure everybody has the same understanding of what you think is going on and what potentially happened, so that the narrative is consistent to the patient and the family. Not that we're trying to control or hide anything. You're actually trying to be as open and honest as possible. But the more confusion in these situations can often lead to uncertainty and other anxieties that are in an anxious enough situation.
Yeah, and I think when a complication happens, I think it's important. Another point back to sort of intraoperative complications is, I think sometimes, especially when you're earlier on in your career, let's say you maybe make a mistake intraoperatively, it's important to just, and this is easier said than done, but really don't have that one mistake sort of impact the rest of the case, right? Because you can easily you can just ruminate over that mistake that you just made, and then it can just sort of compound, and you still have to get through the case, right? You don't, it's bad enough that you got into the, to the IVC, but then don't also get into the, duodenum, because, you've just been ruminating about the fact that you just put a hole in the cava. Because I've seen that happen before. So it's, take one mistake, deal with it, fix it, and then don't let it bug you for the rest of the case.
Yeah, it's hard to have a short memory. It is really challenging, especially when things are not going well. And, sometimes it would be easier to just say, you know what, I'm done for the day and come back. And you can't do that either. That's not right for that patient. So they rely on us, and they rely on us to handle things when they're good and when they're bad. And I think you bring up a lot of really good points. And one thing we haven't talked about yet is preventing complications, right? So we talked a little bit about setting the stage with patients and setting expectations, particularly in complex operations, that things can go poorly. And, if they go poorly, how we handle them and how we're used to them. But then, intraoperatively, and I think that's a good point. And you brought up a great point before about getting other colleagues involved, and particularly junior faculty, people right out of training, right out of fellowship. Let's say, for instance, I do a lot of RPLNDs for germ cell tumors, testicular cancers. In the beginning, every case should have a vascular surgeon involved until when you don't need a vascular surgeon involved. And I've done enough cases now and had enough vascular injuries that I can handle most things myself. But it took a while to get there. And there were some really great colleagues in urology, in vascular surgery, in general surgery who helped shape my surgical career. And my patients would not do as well as they do today if it wasn't for those people. So get them involved. You'll learn a lot from the other specialties as well.
Oh yeah. I mean, I love operating, I'm mostly, in the pelvis. So it's a lot of my co-surgeries are with, gyn-onc or colorectal. And I've become great friends with a lot of my colorectal colleagues, and I've learned a lot from them as well, like you said, because their training is obviously a little different than my training was. So this is how you handle the bowel. This is how, they do their bowel anastomosis a little bit different, and in the way that they set things up and expose things, and the relevant anatomy in the pelvis is hugely important. And so I enjoy those relationships. I think early on when you're starting off your career, you're going to have to build those relationships, right? That all takes time and effort to put into it. But if you start asking around at your institution, who are the best colorectal surgeons to work with, or who are the best vascular surgeons to work with, and a lot of times they're more than happy to work with a good urologist, because we're fun to work with, right, Phil?
We hope so. But actually, this is a great point, and we don't talk about this a lot. On the flip side, how can you be a good consultant when colorectal calls you, or GYN oncology, or whoever it may be? They're in problems. They're in a urologic structure. The ureter's cut. Something's going on. How can you be a good consultant to the other services? Because they're going to have complications too.
Yeah. I mean, there's, and for me, I've already forged a lot of those relationships. So then when they call me, it's like, oh, okay, this is fine. I know who, we've worked together before. So that's another advantage of forging some of those relationships ahead of time. But then you're going to always get those sort of on-call cases that are just going to come up unexpectedly. And what I try to do is I try to talk to the primary surgeon and just see where they're at. I'm sort of in tune emotionally, so I try to sort of see where they're at, because it can always be distressing. I think obviously things weren't going well if they got into the bladder unexpectedly or cut across a ureter, and I just try to reassure them, no problem, we'll be able to take care of this, we'll be able to fix it, not a big deal, and then just go about hopefully fixing it without any additional morbidity. And for me, trying to fix this issue that another surgeon got into, the stakes are high, right? Because it's like I said earlier, you don't want to, compound complications. Now you've got, a severed ureter, and then, you don't want that to turn into a urine leak or a urinoma or a, ureteral stricture. So the pressure does go up, but I think it's important to, once again, restore it can be challenging because a lot of times the setup is maybe not the same as you're used to. They were using a different retractor that you don't like. So I think if you can manage the problem with their whatever setup they have, I think that's fine. But if you're uncomfortable, like let's say you need a different retractor, they're using a Thompson and you like a Book Walter, and you're just not comfortable, ask for a Book Walter. Don't feel bad about that. If you feel like you need a ligature or some other device that they don't have open, you should get everything set up just the way that you like it, so that you can fix the problem that has been made. And don't feel bad about that, because like I said, you don't want all of a sudden have the patient have two problems just because you felt bad about asking for a retractor or whatever device you needed.
Yeah, I think you're absolutely right. And you bring up great points. And just to kind of summarize a little bit, I think the where are they question is a great one. And I always tell people, whether it's your room or somebody else's room and something's going poorly, be the calmest person in the room. Right. So kind of settle things down, slow the field down, slow everybody down. And two practical tips I try and teach our trainees is, the first is what you said, the exposure, right? So think about your exposure, always improve your exposure. So while you're trying to assess what's going on, make the incision a little bit bigger, tug on the retractor a little bit, see if you can expose the quadrant you're in a little bit better. Just to kind of change the perspective a little bit. And that'll buy you a little bit of time to assess the situation. And the other simple one to think about too is, we often forget this, is antibiotics, right? So, now you're in the urinary tract. Most of the time, if it's colorectal, they're covered with their kind of broad spectrum antibiotics. But if you're in vascular, if you're in another service line, they may not have appropriate antibiotics for inadvertent injury into the urinary tract. So just by changing your exposure a little bit, thinking about antibiotics, you've just bought some confidence with the other team. And they're very simple things to do. You bought yourself some time, allowed yourself to assess the situation. And I think the most important thing you brought up was always do the right thing. This patient has already had a complication. That surgeon is beside themselves, as we all are when we have issues, right? Especially ureter. There's like a stigma with the ureter, right? People feel terrible about cutting into the ureters. And listen, they're one of the most commonly injured intra-abdominal organs, and we get it. And we don't have a stigma about it, right? Because we do it too. So we just know how to fix it, so we don't have to call anybody else. But lower the stigma about it and do the right thing, because a fixed complication costs very little, but a complication that lingers or causes problems or results in a lawsuit is a much bigger cost for that surgeon, for your institution, for other people. So do the right thing, get the right exposure. I agree with you completely. Spend whatever you need to spend to make sure you give that the best opportunity of being fixed the first time around.
Yeah, that's right. I mean, I think it's important to, like you said, I mean, calm the room down, right? Because usually the intensity can be pretty high at this point in time, when they're like, oh, it's already probably a tough case if they got into trouble. And so you can come in there as sort of the happy-go-lucky urologist, maybe feel the room out to see if it's a good time for a joke or two. But if not, then maybe keep that for once the ureter is being sewed back into the bladder or whatever it might be. And do the next right thing. I think that was from Frozen 2. But
you and I both have daughters. We know that one well.
So do the next right thing, and that means fix the problem and always do the right thing. And if you don't know how to fix it, I have certainly I had some partners who haven't made an abdominal incision in a while. They might call you if you're the reconstructive urologist. That's okay as well, right? That's what we do.
Yeah. And since the podcast is Operate with Zen, and we're going to kind of put a mindfulness spin to it, I think when a complication or when something bad happens in the operating room or even outside of the operating room, it really is the time to be focused on the moment. You could get lost in all of the things you were doing that led to that issue. You could be focused on all of the things. Oh, how am I going to handle this tomorrow and 2 weeks from now or a month from now? But really focus on the moment. And as you said, you do the next right thing in that moment. You take care of what's present, what's around, and clear everything else. And that's a skill set in its own right. And it takes time, and it takes practice, and it takes more than one complication to figure out how to do that.
Yeah, it does. It's not, I don't think it's natural it has to be something that you're pragmatic about. It needs to be, it's something you can practice, right? If you deal with enough, even if you only have a few complications a year, you could still make an effort. I think in that sense, it's almost harder because it's less frequent of an event. For someone like myself, I've gotten pretty good at it because it's a regular thing. And I've, definitely made an effort to take each opportunity to, um, to manage it carefully so that it doesn't, linger or have any lasting effects. But there are definitely some complications stick with you longer than others. I feel like, and it's those can be really hard, I think, for people to cope with.
Yeah, absolutely. There's a great quote that I'm going to totally ruin right now, but it's by a classic surgeon who talks about how every surgeon carries a graveyard around with them of the things that have gone poorly in the operating room or bad things that have happened to patients. And it certainly does weigh on us all of the time. I mean, obviously we're not thinking about these things 24 hours a day, but there's certainly certain patients and certain complications that we will carry throughout our careers for the rest of our lives. And we hope it makes us better and safer and helps the next patient. That's one way to cope with it and deal with it. But these things can be really, really challenging to deal with.
Yeah, and that's sort of where I think having these types of discussions can hopefully destigmatize the conversation about complications, because a lot of times when we've talked a lot about sort of how do we manage complications, sort of from almost like a technical standpoint, but emotionally, I think that's the area that I think we that doesn't come up too often in M&M, right? When that surgeon's on the hot seats and they're getting grilled and they're, everybody else in the room is saying, well, I would have done it this way, or why did you operate on that patient? All that sort of Monday morning quarterbacking. There's not very much concern for the surgeon's well-being, right? What do you think the surgeon that had that complication is going through? Because there's really, at least in my mind, certainly everybody processes complications differently, but I think they can be, the sort of the buzzwords that come into my head are, shame. You feel ashamed, or there's sort of this shameful feeling when you have a patient have a complication. Like, how do you deal with that, right? All the there's some regret that comes into play. Like, maybe I could have done things differently this way or that way. You start second guessing yourself. You might feel dumb, like, or you might feel, I've certainly felt periods of time where I felt like maybe I'm that sort of imposter syndrome, like maybe I'm not quite cut out for this. Do I really belong? You have a run of complications and you're like, what is going on here? Like, am I doing something wrong? So those are some of the feelings that I think that I've experienced, and I'm sure other surgeons have also felt, amongst others, that I think as a collective group of surgeons, we probably could do a better, we definitely could do a better job sort of supporting, as opposed to just sort of, talking more about how the complication was handled or managed.
Yeah. Tell us a little bit about, do you have kind of a system or a style, when you have these complications, or even how you present or break down in M&M? Is there a way you guys think about this systematically, or is it kind of a one-off?
Well, I mean, the way I've been, I think at all, my training stops, and now here at University of Wisconsin, I think M&M's been handled fairly similarly at all places I've been at, and it's mostly, this is the complication, patient had a wound dehiscence or whatever it might be. This is how it was managed. Here's the literature saying this is how you should manage that complication. And then there's a discussion. And to me, that always, as it just always, maybe not always, but more recently, as I've thought more about how we talk about it as in most departments, at least the departments that I've been part of, it just leaves me feeling a little bit empty. Like there should be, yes, it's important that we teach our trainees how to manage wound dehiscence and other complications, infectious complications, bowel complications, whatever it might be. But I don't think, so that's sort of how it's been discussed in the departments that I've been part of. I don't know what your experience has been like, Phil.
Yeah, I think very similar. And, listen, coming from a very traditional surgical training program, I mean, we used to get excited as residents, like, oh, the sharks are circling, right? I mean, things could get pretty heated in these conferences. And, my first response to that is we should be more supportive of each other because nobody's immune from complications, right? And it shouldn't be the sharks necessarily circling. But I've also become more familiar with the concept of kind of extreme ownership. I don't know if you've heard this term. Paul Moroney brought it up in one of the prior podcasts, but it actually comes from the Navy SEALs, and in their kind of they call it after action reviews after a mission, and it's basically an M&M for their mission, and it's taking extreme ownership over what happened and what you could have done better. And it's okay to be heated, and it's a very safe space to do that in. And the analogy, I think, from surgery to the Navy SEALs mission, one that I think about and I share with people is, we love to blame the patient in a disease state, right? And that's the first thing we say. Listen, it was a sick older patient. They had lots of comorbidities, and it just didn't work out right. Something bad happened, and there's some truth to that. And the Navy SEAL analogy is, all right, well, we went on a mission, and the weather was bad, and it blew the chopper off course, and we didn't land where we were supposed to do, and the mission didn't work out the way it was supposed to. And the extreme ownership in either circumstance is saying there's some of this that's on us no matter what. And that's really the truth of it. And so for the Navy SEALs is, well, maybe we could have done better weather forecasting. We could have tried a different, company to kind of scout out what was going on in the area, or had a better understanding of weather patterns in this region of the world. And for us in surgery, I think it's really being honest with ourselves, which is really hard to do. And so I've kind of, I have a little system that I walk myself through, and I try to walk our trainees through. And the first part of it is owning the emotions, because they're tough. They're really tough. And the more you push them off, the more they cloud your vision. So just own them, let them wash over you, whether it's good, bad, ugly, the shame, the guilt, whatever it may be. Own that emotion. Go listen. If you want to go have some tears, or you want to go scream, go do that in private, right? If you don't feel like sharing that with everybody, but own the emotions, because if you don't, then it's just hindering you from moving forward. And then it's the classic quality stuff, right? What are the system-based errors? But also, what are the personal issues here, right? What did I bring to the table that could have impacted this, right? Was I feeling overconfident in myself that day? Was I feeling burnt out, right? Did I not have support in clinic that week, and I made a mistake on the preoperative imaging, or I should have got a better CT scan, but I just moved ahead because I was tired and burnt out? And the bottom line, what we're trying to get to, whether we use the term extreme ownership or M&M or quality, is that we're trying to get to the truth. And you can't get better unless you really understand that truth. And it is not easy.
Yeah, I like that analogy. I think it's so true that a lot of times we'll blame the patient, and I really hate doing that. It's, oh, they were too obese, right? Like, I mean, yeah, that's a fact. But but I think it's not fair for them, right? I mean, you could say, well, yeah, they couldn't control it, but obviously that's debatable. But it's not good, like you said, it's not good to blame the patient. And there are other alternatives to surgery potentially. And I think your point about owning the emotions is that's sort of the realization that I came to as I was experiencing complications myself, was that that's the part that I think we don't talk much about in the field, and that's I think what I want people. One of the things I want people to take home from our discussion, Phil, is that the emotional toll that it can take is immense if you don't deal with the emotions in real time. in real time. And that could mean, find a friend in the department, or, get on a podcast and talk to somebody, whatever it might be, so that you can talk about whatever complications. It's probably better to have somebody in your own like department that you can like get, that you trust, trusted confidants that you can sort of, spitball about certain complications with, because then you can be more specific. You can say, oh, this is going on with my patient. This is how I feel, right? It's I know how to manage the complication, but I feel like crap, right? Or I feel this terrible amount of shame or regret or whatever emotion it might be. But you can't, there's certainly, you can't talk, you may not feel comfortable talking about those feelings or emotions with everybody. I spend a lot of time talking to my wife about certain things that happen at work that are emotionally taxing, and complications included. She's not in the medical field, so I mean, she's very smart and can understand a lot because she's been with me since medical school. But she's a good person that I can sort of bounce things off of, and she can tell too when I'm feeling sort of emotionally exhausted, and usually it's because of something going on at work, and she does a good job of getting me to sort of talk about it and get it off my chest so that I can be present with my kids and her at home and not be ruminating about these complications, because that's the issue that happens. Is if you don't deal with it emotionally, I think it's gonna impact your personal life. You might, there's certainly, like I mentioned earlier, surgeons and suicide is a real thing. Surgeons and substance abuse and all that is a real thing. And I think part of it probably stems from not being able to handle the emotional toll that we take from dealing with complex patients and patients with complications, also patients that just have bad outcomes. It may not be a complication, but you've got a patient that dies from their cancer or from whatever urologic problem they have. That can take a big toll on you as well. So you got to find someone you can talk to about it, and be able to deal with those emotions.
Yeah, I think that's a huge point. And I think the point of stakeholders is incredibly important. You need stakeholders in your life. And you and I talked about this last time. And my wife is in medicine, and I don't bring these things up with her, which is kind of the funny opposite and parallel, right? Because she has her own stuff that she sees in the day. And so, listen, if something's really going on, obviously I can share anything with my wife, and she's a great support for me, but I try not to do that. But I have stakeholders in and outside of the institution, people I call, and I just say, hey, man, this has been a rough day, or this is a rough complication. Can I run this one by you? And you're right. When you're calling somebody like that, it's not how to handle the complication most of the time, right? We know how to do that. It's the emotional unloading. And I've learned over the years to just listen to people when they call with that. They don't actually need you to tell them how to manage IV fluids and what consultants to call. It's just to be an ear for them and let them kind of open up about it. And as surgeons, we always want to give the answer. Oh no, you call GI and, get this thing done and do that test and that study, and this is going to help. Yeah, you can save that stuff for the end of the conversation, but just listen, just be an ear. People really do need to open up and talk about these things.
Absolutely. Yeah. I think when I call somebody, it's rarely because I need help managing the complication. Occasionally, once or twice, I can think of where I've had something really weird where I'm just like, I'm not sure what to do. I need your opinion. But yeah, a lot of times, I'm calling because I need to vent a little bit, or I need to get those emotions out in the open. And I think you got to find somebody that you trust that's willing to listen, right? Like you said, and not just say, oh, this is how I would manage it. Like, that's not helpful most of the time. So, and then the other piece that I wanted to just mention, Phil, is I got a text from one of my colleagues. This was a few years ago, that I thought was incredibly helpful. It was actually a little bit more senior colleague of mine. And I must have had a rough patch with some of the M&Ms going on, or what might be. But my colleague texted me just out of the blue and was like, Kyle, I know you're a great surgeon, and you've had a little bit of a rough patch, I can see, but don't let that get you in the dumps. You're a fantastic surgeon, and your patients are lucky to have you. Something along those lines. And the reason I bring it up is because it really lifted my spirits when I was kind of at a low point. And this was earlier on in my career where I didn't really, I would say, have a system for managing complications, at least an emotional system in place. And at that point, it really lifted me up. And I don't think the person that sent me the message, and maybe it was intentional, I'm not sure, but it really made my day and lifted my spirits. And I was like, yeah, he's right, you know. So I would say look for opportunities, all you surgeons out there, to do that with your colleagues. If you notice, you know, but you got to pay attention, you know, you got to be on the lookout for people that might be not doing as well, or but don't hold back. I mean, I think a lot of us can use little uplifting comments like that day in and day out. At least it helped me out, and I'm sure it would help out many other people that are struggling with whatever it might be at the time.
It always amazes me how the great mentors in your life always know when to be there. And I don't want to know if they actually know, like if somebody else called them or if they just happen to kind of instinctually know when to reach out. But it's amazing how the good people do that. And I think you're right. I think it's because they listen, and maybe they haven't heard from you in a while, or maybe your communication pattern's been off with them. But the really good mentors and supporters out there know how to be there for you, and they know when to be there for you. And I can only hope to be that for other people. I think it's incredible. I want to bring up, I think you were transitioning into a beautiful segue that I think really needs to be talked about. Is we've spent the first half an hour plus here talking about complications and when things go poorly and how we deal with them. But we often forget, you know, not that we forget, I mean, we are part of a team, and our teams are dramatically affected by these. In academic institutions, our residents take on the brunt of patient interactions. And even though we may go see the patient and the family 2-3 times, we may be on the phone with them more frequently than we are with other patients. The residents are rounding on them on a daily basis. They saw everything happen in the operating room. They're handling some tough, you know, phone calls and consequences. Our nursing teams, the anesthesiologists, our office staff. And, you know, you brought up kind of the idea of the second victim syndrome, which is, you know, us is the primary provider. But whether you want to call it second victim or third victim, right? Our care teams really struggle with these complications too. So how do you address it with your care teams, with your trainees, with the other people involved? Because I think that's the other part of this that really needs to be addressed.
I think it just starts by, at least for me, I'm very open and transparent with the entire team. So when I'm, you know, I just talk about it almost probably incessantly, just to make sure that people feel comfortable, you know, talking about, you know, the patient and their, you know, maybe, you know, their complication or their bad outcome that they're experiencing. And I also try to not play the blame game. I think it's easy to say, well, it was so-and-so's fault, or, you know, so, you know, obviously sometimes, you know, it is somebody's fault. If there was a medical error, that certainly can happen. But I don't think it helps to start pointing fingers or blaming people, or even blaming residents if there was an error made by one of the residents. I think it's important, though, if there was a mistake that somebody made, to talk about it. But to talk about it in a safe place where people can feel comfortable to learn from that mistake. I'm a big believer that you can, you know, every complication you could potentially learn from, or any mistake that is made is a learning opportunity. So I try to talk to the residents about it continuously as it's ongoing and in real time. It's important to not, you know, do it, you know, weeks later when everyone has sort of forgotten about it, and they're dealing with sort of the aftermath. But to do it in real time, or to have a sort of a debrief at the end of the case, if it's an intraoperative complications, I think it's a good time to do that as part of your debrief. And then the nursing team can be a little bit, I think you're right. They're definitely they're the ones at the bedside, you know, dealing with it. So I think I also try to just communicate with them as much as possible and talk to them about how they're feeling and what's going through their minds. I think it's important to deal with their emotional aspect as well, because I think the nurses are probably a little bit more in tune with that than, you know, the gruff surgeon might be. So I think it's important to get everybody involved and to make sure that everyone's on the same page.
Yeah. And I think the other part of that is just acknowledging people's efforts and their struggles, right? Whether it's our trainees to say, man, that was a rough day. You doing okay? And to say to our nurses, like, thank you so much for dealing with this. You know, basically I put you, or we put you in a really tough situation, and you have been a tremendous asset to us and to the family and to this patient going through this. So thank you so much for that. You know, it goes, acknowledgments and gratitude and thank yous go a really long way in the hospital.
Yeah, I think so. And I think you just, I think you hit the nail on the head there with the gratitude piece. I think it's being thankful for all their efforts, and yeah, the patient may not ultimately have a good outcome. They may not recover. Or they may even pass away. But you can still be thankful, and you can still say, you know, to the nurses or even to the family, we gave it our best. We did everything we could. We tried our hardest, and I've had to do that with, you know, unfortunate patients that didn't make it, and usually the family is, they get it. They, a lot of times, if you've done a good job sort of managing the situation, if you want to use that term. I've had patients have terrible outcomes, and the families thank me, and I'm like, I'm not sure I deserve this thanks, but they're, you know, they're more thankful for me trying, for me being there, for my emotional support. They're thankful that I did everything that I could to help out their loved one. So that it's a little bit odd for me when they say that, but just about every time I've had a patient have a bad outcome, it's, you know, I think the families can see that it hurts me, right? There's a lot of hurt that I take. So it's unusual. I don't feel quite right when they thank me, but I know what they mean. I don't know if that makes sense, Phil.
Yeah, no, I do. And, you know, Tate Shanafelt, who's at Stanford and on this season of the podcast, talked about us being humans and being doctors or being surgeons, right? And that human part is what really helps us through these tough times. And it's connecting with patients at a deeper level and really understanding where they're coming from and showing them where you're coming from. And I think that's what builds the best relationships and honestly what makes our job the most magical.
Yeah. Yeah. Well said. Well said, Phil.
So Kyle, we're getting short on time. You know, what else do you want to cover? What else do you want to talk about with, you know, complications or when things go poorly? You know, what else do people need to hear about?
I think we covered a lot, Phil. I mean, we talked about, just to summarize, I mean, we talked about how to sort of manage the complication as it's happening. And then I think the other big piece really is the emotional piece that I think we could do a better job of managing. And it's something that I've worked hard on since I've been in attending to get better at. Not easy. It's not easy to manage the emotional side, because I think a lot of times, I remember my training, you know, we're taught, you know, nobody really cares too much about your emotions, you know, just suck it up, deal with it. But that's a big piece of what we do. And if we're not in a good headspace emotionally, you know, that could impact our ability to care for patients in the future, and as well as impact your health and your other relationships outside of work. So I think dealing with the emotional impact that complications, the toll that it takes on you, is critical. And to do so, I think, talk about it. I think you have to process it. You have to talk to people about it. Talk to a spouse. I found some sort of friends, confidants within the field that I could call and talk to about how I'm feeling about certain complications. I think I wish it was more, grand rounds was more touchy feely and we could talk about it at M&M, but it seems like they're some of the traditional institutions, you know, like Hopkins, Penn, my institution, maybe aren't quite ready for that yet, but that doesn't mean we can't try, right, Phil?
Yeah, I agree with you. I think, you know, I think that's a great theme for this is kind of challenging everybody out there to engage with the emotional side of this and model good behaviors. Talk about it in the operating room, talk about it on rounds, talk about it in M&M, and check in with people in a public way. Yes, you should do it in a private way, absolutely, but do it in a public way too, and be able to say, this really affected me, this really bothered me for these reasons, and be honest, give your reflection. I think these are all great points. And as you said before, we seek band-aids for these issues, right? What you talked about, we talk to people, we may have a drink, we may have more than one drink, you know what I mean? There's ways that we can deal with them. We may go on a run, we may do something physical, but those are band-aids. And until you actually engage and own the emotion and own it with the people who are experiencing it, it's going to weigh on you. And I think that's a great message for this podcast, Kyle.
Yeah, I think that's a good one to end on, Phil.
Yeah.
Thanks
So let me do, I'm sorry.
Thanks for having me.
Yeah, it's always a pleasure having you. I just want to summarize some of the really great things you said throughout this podcast. And we started by talking about what's not talked about, right? Complications and how they affect us. You gave great advice on how we should manage these things, whether intraoperative or kind of post-operative. Be present. Don't be afraid to apologize. Load the boat. Phone a friend, whatever your analogy is that you like there. We talked about controlling the narrative and giving kind of a consistent story to families. And then we really talked about, being calm, doing the right thing. Don't compound one mistake into multiple mistakes, and engage other people. Engage them not only in the management of the complications, but the emotions. And that's really our take home. These complications, or when things go poorly, they affect our patients, they affect those patients' families, they affect us, they affect everybody on our care teams. Gratitude and open communication, honesty and emotion, I think, is the sign of a mature surgeon. And I think you've helped relay that to the audience today.
Thanks a lot, Phil. Yeah, I think that's a great summary. And I hope that other physicians, surgeons, anyone that's listening to this can learn a few pointers and take it back and put practice, right? Because that's how you'll get better at this. It's not something that I think is natural for a lot of people dealing with a very unnatural occurrence like complications. So it does take practice. You have to be intentional and be aware of that there are, I think there are many downsides to not handling complications emotionally, because it will add up and lead to bigger problems, I think, in your personal life and professional.
Absolutely. Well, thank you so much for taking the time and sharing. I know there's a lot of people who are going to benefit from this conversation, and I hope you have a great day and a complication-free week.
Thanks.
All right. Talk to you soon.